Start.
So continuing our conversation with regards to tools and instruments that we can use, the conversation is directed towards medical students, residents and interns and anybody interested. The question asked is, why should we do this? The answer is very simple. So that we get better, so that we don't go through life in the dark, and so that we can illuminate and enlighten each other. That's the reason to do this. If you ask me personal stories, most of the time we wondered whether the trouble was worth it all going through medical school and training ourselves. And sadly, we figured that once we were done with medical school, whatever we learned was not enough, or whatever we thought we had learned was no learning at all. And therefore our task should be to improve our learning. So these tools, or the toolbox, if you want to call it, are certain tricks of the trade, if you want to call them that. And today I will talk a little bit about pressure. So what is pressure? Specifically I am referring to blood pressure. So the question asked is, what is pressure, to start with before we talk about blood pressure? Pressure is defined as force upon area, or force divided by area, and that's the equation from physics knowledge. And force is mass times acceleration, so pressure is mass times acceleration divided by area. When it comes to blood pressure, what we are talking about, the mass of blood divided by the cross-sectional area of the blood pressure, of the blood vessel. Therefore, if the area of the blood vessel increases, the pressure will go down. If the mass of the blood that is flowing through the blood vessel increases, then the number of particles of blood that are exerting their influence on the sides of the blood vessel wall will increase. Therefore, the blood pressure will increase. If the cross-sectional area of the blood vessel decreases, therefore the denominator for pressure, which is equal to force upon area, and the area is decreased, so force upon area will increase, therefore the pressure will increase. Now, how do we use this knowledge and definition of pressure to describe the two blood pressures that we deal with in our routine clinical life? We have the systolic pressure and we have the diastolic pressure. The systolic pressure comes from systole and the diastolic pressure comes from diastole, or is recorded at the end of diastole. Therefore, systolic pressure, if we say is recorded during systole, what we are talking about is, as the heart contracts or goes into systole, it ejects a certain volume of blood. This volume of blood flows through the blood vessels. As it is flowing through the blood vessels, it is exerting force on the blood vessel wall, and that is the reading that you get as your systolic pressure. So what is diastolic pressure then? The diastolic pressure is the left ventricular end diastolic pressure, meaning once systole is over and as the heart is starting to relax, when the left ventricle has reached the end of diastole, the pressure that remains in the blood vessel, or the column of blood that is exerting pressure on the blood vessels at the end of diastole, is the diastolic pressure. How do we use this knowledge clinically? We have defined what is systolic pressure and we have defined what is diastolic pressure. Starting with defining what is pressure to start with, and when you record it with your instrument, with your sphygmomanometer or with any other instrument for that matter, those are the two pressures that are recorded, and those are the two mechanisms which give you the systolic reading and the diastolic reading. So how do you use this knowledge? to define somebody with higher blood pressure and what pathophysiologic interventions we can do to improve those readings. So to take it one step further, if you want to reduce systolic pressure, you can increase the area of the blood vessel or the diameter of the blood vessel, or relax the blood vessel. You can decrease the amount of the blood column that is exerting force on the blood vessel wall. So you can decrease the amount of blood or the cardiac output that is flowing through the blood vessel. If you want to decrease the cardiac output, you can decrease the rate of the heart, or you can decrease the volume of the blood, or you can decrease the force of the heart. So these are the mechanisms for reducing systolic pressure. To reduce diastolic pressure, you can increase the diameter of the blood vessel or the area of the blood vessel, or you can try to reduce the column of blood that is exerting the residual force on the blood vessel wall. Now when you think about all your blood pressure medications, they act either or in combination of these mechanisms to adjust systolic pressure and diastolic pressure. Therefore, the takeaway from the conversation is, when you are defining systolic pressure and diastolic pressure, just bear in mind the mechanisms and the definition of pressure by itself when you are getting a reading for high systolic pressure and for high diastolic pressure. Further caveat would be, when you are defining diastolic pressure, keep in mind that if the elasticity of the blood vessel decreases, what you have will be elevated diastolic pressure. The reason you will have elevated diastolic pressure is because the arterial wall has to have enough elasticity or enough stretchability to accommodate the force that is being generated by the column of blood at the end of end diastole. Therefore, when you have a high left ventricular end diastolic pressure, or when you have a high diastolic pressure, or when you have a low elasticity of the vessel wall, you will get high diastolic pressure readings. There are few ways to reduce, to increase the elasticity of a blood vessel, because that is what you are genetically made of, that is what anatomy has changed in your blood vessel wall, that is the way the arterial wall has become. Therefore, the diastolic pressure readings, if they are high, do indicate certain advanced changes which relate to high diastolic pressures. It's not very usual to have isolated high diastolic pressure, but that is by definition the mechanism for having high diastolic readings. When you will get high systolic readings, the usual mechanism is a combination of these. The output may be high, the arterial elasticity is low. So when you have a combination of this, you get high systolic readings. It's much more common to find high systolic readings than high diastolic readings. Therefore, bear in mind the mechanisms of generating systolic pressure, and bear in mind the mechanism of generating diastolic pressure. Keep in mind left ventricular end diastolic pressure, which is a very important commodity or component of your blood pressure readings. Alright, thanks very much.